Okay, I think it's a good time to. Start. If we can start getting back into our seats here. My name is. While the slides are loading up, my name is Alok Sharan. I'm an orthopedic spine surgeon in Westchester, New York, right north of New York City, and I have the distinct honor of being the moderator for the final session for the MHCDS, our MHCDS Symposium. Thank you, Lisa. Thank you. First of all, thank you for being awake. I really appreciate that, acknowledging that. So when we first started thinking about what we wanted to do for this last session, we tossed around a lot of different ideas. We thought that maybe we can use it as a summary section. We could talk about resilience and surveillance and alignment and whatnot. But then as our colleagues and I started talking about it, we said, you know what, let's try to do it a little bit differently. We've heard a lot about change. We've heard a lot about transformation over the past 48 hours. I mean, some incredible ideas. And what we wanted to do was sort of drill down and be a little bit more granular about what change actually looks like. Sort of the roll your sleeves up, taking out the garbage kind of view of what change looks like. So the goal of our session today, which is titled Dimensions of Implementing Change, are really just one of those roll your sleeves up, what does change on the ground actually look like? That's what our hope is. Our hope today is that you'll come away with one or two tidbits of information that you can use in your systems as you're trying to implement change. Now, before I begin, I wanted to just thank a couple of people for helping put together this symposium. First, you'll hear about Suellen and Andrew Sorenson, my co-presenters, Carol Ash and Raphael Barra, who's not here today, but they also helped tremendously in putting together this symposium. And I wanted to thank Molly, who's been our partner in crime, who's had to hear about all of our crazy ideas about change and helping put us all together. But more importantly, I wanted to first thank all of you for staying till this last session, and thank all of you for the ideas that we've been discussing. I think all of you would agree that this is the goal. I remember in 2013 sitting in the MHCDS program, and Bob Hansen talking about the $3 trillion healthcare problem, and all of us came away thinking that we want to be at the top of the mountain, right? That's why we're here today. We all want to be at the top of the mountain. But the reality is that most of us live and work down here, at the bottom of the mountain. I'm not much of a mountain climber, but I know enough that when you're at the bottom of the mountain, the challenges you face at the bottom of the mountain are much different than the challenges you face at the top. And it's pretty clear that as you rise on the mountain, the tools you need, the problems you face are certainly very different. And so in looking at this mountain that we call the $3 trillion healthcare problem, it's pretty clear that we've got to segment all these different levels and think about the different tools that we need. So after graduating from the MHCDS program, I wrote this article with Dr. Weinstein about the science of healthcare delivery. And what we attempted to do is sort of break down the healthcare system from a management structure point of view and thinking about what are the different tools that you need at the different levels, right? And so it's pretty clear that at the very bottom level is the patient-provider level. It's where many of us live and work at every single day, and to some degree where real value is created. And right above that, providers often work together in a department or perhaps in an institute. But clearly the dynamics at that level are different. It requires teamwork, coordination, and different problems come about. And then there's, of course, the different departments come together working in a hospital, working in a system, and the dynamics are clearly very different, and the tools for transformation are very different. And at a very much larger level, you have this sort of state and federal level. And there's no question that the tools for transformation at that level are much different than the tools that you're going to require at the other levels. Why is this important? Well, I'll give you an example. Let's just think about the different levers we have for transformation. Let's think about these alternate payment models. The way I see it is that, for example, if you look at, I'm simplifying this tremendously, but if you look at pay for performance, where you incentivize a physician to order mammograms or colonoscopies, that works really well at this level over here, right? But it's unclear that as you go up, what kind of effects you're going to have. I think the bundle payment program, from my experience with joint surgery and spine surgery, you're trying to incentivize the groups of providers to work together. And so the effects you're going to get are going to be at this level over here. And then I think the ACO programs really tries to incentivize a whole hospital or healthcare system to work together that get those levers. And it's unclear to me at this level, perhaps SGR and MIPS we're not really clear about, but I think those kind of programs work really well at incentivizing at the state and federal level. But why do I bring this up? I think what's been so challenging about healthcare is that there's this mismatch sometimes in the levers that you're using and the effects you're going to try to get. I think that a lot of times, for example, the provider at the bottom level may not feel the dramatic improvements from the ACO program, and you get this mismatch sometimes. I don't have the answer for that, but I can certainly see that in the hospitals I've worked at, that mismatch, the incentives at, let's say, the hospital level, they get diluted when you get down to the provider level, and you don't get those behavior changes that are so critical to making those, to getting the outcomes we're looking for. But this is just a very simple framework I wanted to present today in the context of this symposium. Because what we try to do for the symposium today is start with speakers who can speak about transformations at these various levels. And so to begin with, Andrew Sorenson from Intermountain Healthcare, he's going to be speaking about how he's looking at a whole system-wide transformation where he's trying to get integration across all the 20 plus hospitals in the Intermountain system, how to get sort of service line integrations. Suellen, she works at the West Central Behavioral Health Center. She's the CEO. And what she tried to do was get that institute to bring their wait list down from 220 patients plus down to 0. And me, I'm a factory worker. I'm an orthopedic spine surgeon. I take care of people with spine problems. I'm going to speak to you at a very ground level about how I just wanted to get patients who are waiting 3 weeks, for patients with back pain who are waiting 3 weeks to get in, and try to get them in within 24 to 48 hours. Okay? So it's this context that basically I'd like to use as our framework for the different talks that we're going to be giving about for the levels of transformation. So with that, I'm going to take the liberty of being the first speaker today. My talk is entitled Improving Spine Care from the Ground Up. So on a day-to-day basis, this is what I take care of. This is a patient who I had the opportunity to take care of a couple years ago. This is Mr. JP. JP unfortunately had spine surgery a couple years before I met him that failed. He developed this condition where his chin landed on his chest. He could not see, he could not eat. It was a significant problem. And through a very complex surgery, we cracked his neck, made him straight, and really impacted his life. The surgery itself was technically very challenging, but you can imagine that before and after, the coordination involved with other doctors and other services to get that kind of result is challenging. Putting it all together, it was very challenging, but the impact that we had was great. The problem with spine care, I would argue, is that it requires that level of coordination to get a good result. And part of the reason why we're having such a hard time getting improvements in spine care is that it's not just one doctor who can make a difference. It really does require a whole team and coordination of a lot of different services. And so I know many healthcare systems are struggling with improving the delivery of spine care. It is a challenge. It's a challenge that our country faces. It's an $80 billion challenge. That's about direct costs. I'm not even including the indirect costs of missed work and whatnot. And as I said earlier, part of the problem is that there's tremendous variation in care. And a lot of researchers here at Dartmouth helped us understand that. But beyond the variation pieces, of course, there's a lot of fragmentation, uncoordination. So you can see that it's a very big challenge to solve. But serving on a lot of national committees now, I could tell you that we're working really hard to improve the evidence and get rid of the variation and the fragmentation. So there's a lot of good work actually being done now in our spine community to try to reduce some of those problems. But why is it a problem? I'm sure many of you right now have back pain. If you don't, you'll get back pain, because back pain is one of the most common reasons why someone visits a doctor, second only to, let's say, upper respiratory tract infections. And I tell my patients all the time that back pain is just like the common cold. Often it gets better by itself. When you have the common cold, or we all had this terrible flu season, you may have gone to CVS and you self-treated yourself, right? That's normal. I don't want to see a doctor if I have a cold. The problem with back pain, though, is that it's not that simple, because I've seen it more and more commonly that patients who have back pain, they think they're going to become paralyzed, they have cancer, and it leads to a whole bunch of other problems from there. So while back pain will often get better within a few weeks by itself, I think the psychological impact of having back pain is what's causing some of the problem. So as I said earlier, most cases of back pain will get better by themselves. Actually, for me, it's a great visit. Patients come in, I reassure them, they do well. They're going to usually get better by themselves, but they often get better just with time. And just with just simple rest, they get better. But a lot of times, I could just tell you that patients truly feel that they're going to become paralyzed or they have something bad going on. And so they need reassurance. So I think that I've learned over the years that with back pain, probably less than the common cold, rapid treatment leads to better outcomes. Now, when I make that statement, I'm not trying to say that rapid treatment with medicine makes a difference or rapid treatment with this procedure or that procedure. I think rapid treatment includes just something simple as reassurance. That the patient just needs to be reassured that everything's going to be okay, they don't have anything serious on. And if you can get that patient in to see you quickly, you can reassure them, rapid treatment, and things will get better from there. So my hypothesis for treating spine pain is that if you can get them in early, if you can improve access, you're going to be able to save a lot downstream. That's my hypothesis. So there's some economic argument to this. This is data from Blue Cross in upstate New York. I forgot the name of what the Blue Cross company is in upstate New York, but they've shown that the average cost of treating a spine episode, if the patient only has problems for 3 months, the cost is usually about $1,000. That's not including surgical costs, though. But if the pain does last more than 3 months, it usually goes up to about $3,000. So there's about a $2,000 cost savings if you can basically get to that patient early and treat them rapidly. So there's definitely an economic argument for why you want to get them in quickly. So going back to this mountain analogy again, my goal is to solve this $80 billion problem. There's no question that it's going to come through some kind of payment reform. And there's no question that it's going to come through some coordination and getting rid of the fragmentation. But to me, at the root cause for dealing with spine pain is solving the problem of access. So, but 3 years ago, after finishing the MHCDS program, like many of you, I changed jobs, and I moved from an academic hospital to a private practice in Westchester County called WestMed. This is just a little bit of geography. New York City is south of us. Connecticut is to the northeast of us. WestMed is a fairly large progressive practice. We have 6 major clinics throughout the Westchester County area. There's about 400 physicians, multi-specialty with a huge primary care base. And in each major clinical site, we have primary care specialists, imaging, so patients can do a sort of one-stop shopping within the sites. So it's a very, very well-run, efficient practice. They see about 1.2 million patient visits a year. About 300,000 of them are unique lives. And they understand the value of efficiency. They understand the economic value of efficiency. They're part of ACO contracts. And so WestMed has been moving towards value-based contracts for a while, and they're doing pretty good at that. But even with that level of efficiency and having the right infrastructure in place, it was still about 3 to 4 weeks before a patient with a spine problem can get in to see a provider, right? And so when they hired me to be a spine surgeon, but they also hired me to help sort of improve the delivery of spine care overall for the whole system. And so the first thing I did was sort of just get a lay of the landscape and just try to understand how could a practice which is so efficient, which had tremendous quality scores, even they suffer from the fact that it was 3 or 4 weeks before a patient with a spine problem can get in. So part of the problem with spine, if any of you are thinking about trying to crack this nut, is that spine care, low back pain, is not one disease. It's very, very rare that a patient has a problem in their back because of a pinched nerve or herniated disc down here. When that's the case, they should be seeing the appropriate providers. Most often, though, most people have just sort of a back sprain and poor posture, simple things like that, and they should be seeing these type of doctors. And it's not uncommon that a bad day at work or fighting at home can also lead to problems in the back or neck. And so they should be seeing these kind of providers. The reality is that someone with a pinched nerve will often see, let's say, a chiropractor, and someone who's depressed will often see me, which I'm a spine surgeon. I'm not that good at dealing with depression. So this mismatch is what really the problem is with spine care, because you can imagine that back pain itself should be fragmented into different diseases. And so if you can get the right patient to the right provider in the right period of time, you can solve that. To me, that's a process engineering problem. So when I took the job, sort of started getting a lay of the landscape, and I had a little bit of insight about what generally the problem was, I really started drilling down further to get at a root cause how we can solve these problems. So what we did first was, I was really fortunate that some colleagues who were sort of helping with me, we just sort of listened. We did, as Dr. Conway mentioned yesterday, surveillance. Spoke to the patients, spoke to the providers, just to get a sense of what the problem was. And we found that everyone's complaining about the same thing, access. The patient said, I had pain in my back. I was worried I was going to become paralyzed. I couldn't get an appointment within a couple of days. Went to the ER. The primary care doctor had a patient who had back pain. They weren't comfortable taking care of it, didn't know what to do, send them to urgent care or the ER. So it was a recurring theme over there. So access was clearly a top-of-the-line kind of issue. And then beyond that, there was issues of coordination, right? And then issues of just from the system perspective, from the WestMed group perspective, issues of cost effectiveness. So for the purpose of this presentation, I'm just going to concentrate on the access part of it. But clearly, those other two were also very important issues. But we prioritize access as being the first problem that we wanted to go after. So as I mentioned before, and this has been borne out in multiple different studies now, that patients will often go to the ER if they can't get access to a physician within 24 to 48 hours. And it's that fear and anxiety which is leading to them to go to the ER. It's not maybe any kind of real pathological problem. They're not actually paralyzed or they actually don't have cancer. And then beyond that, when patients do get pain and the anxiety levels start to increase, that's when you get this sort of random movement, I call it, where the patients may see the wrong provider. So they need to be guided properly. And at this point now, they'll just go to see any kind of doctor, which often can be the wrong doctor. And so as we're sort of taking down this problem, what we did was sort of try to understand the pathways these patients were taking. And I think you must have done the migraine case. And migraine has the same kind of problems that back pain does. So it was really nice for me to sort of go through that case. But one of the first things that we did was actually just process map what a patient goes through. Going through the EMRs, speaking to the patients, we sort of just try to understand when a patient has a back problem in the WestMed system, what's the pathway that they go through? And this is sort of a typical pathway. I call it the ping pong effect. Patients were just sort of playing ping pong all over the place, right? And this leads to a lot of wasted visits, a lot of wasted imaging, just a lot of waste overall. And so then we said, okay, fine, so on average, this is what our patients are doing. What is sort of the ideal state? And we re-engineered and redesigned that process and said, what are our major entry points? It's often through a primary care doctor or urgent care or even sometimes just off the street. And what we did was we sort of re-engineered the whole process. So patients will be seen by a spine provider and then be put into a particular pathway based off of what their problem was. So that's what our ideal state was. And to get there, what we did was, I wanted to just talk about this. So who you start with first makes all the difference, I think, in spine care on multiple different levels. But Optum actually did this really wonderful study where they showed actually that if a patient starts with a physical therapist or chiropractor, their severity adjusted total episode cost is 30% lower. So beyond just the clinical implications of it, there's tremendous economic implications. So that's why we knew that concentrating on this first step is so critical. Everything else will follow from there. And that's why we put a lot of time into just trying to figure out what this first step was going to be. And so our goal was to achieve better access. And we set our goal as trying to get a patient with a spine problem in within 24 to 48 hours, bringing it from 3 weeks down to 24 to 48 hours. So we spoke to our orthopedic surgeons and we spoke to our rehab physicians and asked them, are you willing to see spine patients same day, next day, or within 48 hours? They all said, some of them said yes, some of them said no. But we took the 6 that said yes and said, we started doing sort of a capacity calculation. And just looking at their schedule over a week and saying, how many open visits do they have? Because we wanted to get a sense of how many people we can sort of handle. You can imagine this back pain is a pretty prevalent problem, but could we handle all these patients who are coming in? Came up with a number. And then working with our call center operator, what we did is sort of a stress test. So we sort of came up with fictitious 20, I think, patients a day. We would try to sort of schedule these fake visits to see if they can be scheduled, in what time period, just getting a sense of what we could do, what we could handle. And then beyond that, beyond just trying to figure out the numbers that we can schedule, we also wanted to see which offices they can be seen in. Because geography is a big problem. I think for most systems, this is what I see. Ideally, it'd be great if we had one central location and say, this is the spine center. That's not realistic. We have offices down in Yonkers, and this could be about 20, 30 minutes away, 20, 30 miles away. So when we did this stress test, what we did was find out that, okay, we can see 3 people here on an average basis, 5 over here, 7 over here, and which was probably not acceptable. We wanted to make sure that we have equal numbers at different places. And so we tinkered, got more providers on board, and sort of just in a very iterative fashion, doing these stress tests, getting a response, and then adjusting accordingly and getting more providers on board. And then with that, what we did was say, fine, let's start with something simple. We want to control where the patients come into the system and then get them to the right location from there. And so we created this phone number. 914 is the local area code, 43 spine. And that was kind of interesting how we came up with that, because we went through a lot of different iterations. So for a whole week, we did a Google analytic. So we typed in Westchester Spine Center, Westchester Back Pain Center, back pain, and within Google, you can do tremendous analytics about, in your geography, what are the most common hits. And we found that on a 7 to 8 times basis improvement, that most people are more likely to enter in spine pain over back pain when they're trying to look for a spine provider. And so we knew that just trying to get the word spine was going to resonate more with those kind of patients. And so that's how we came up with the number 43 spine, and then we launched it. And actually, when we first launched the number, we had this complex algorithm trying to ask them this kind of question, that kind of question, all that kind of stuff, and it didn't work out. we were trying to get if the patient needs surgery, get them to the surgeon, this, that, it just didn't work out. And this speaks to the whole notion of trying to keep it simple. And so every other week, we would have a phone call with our call center. And in that phone call, we actually would audit phone calls, real phone calls from patients who called our number. And just to get a sense of the conversation about what the patients were asking with back pain and whatnot. And then using that, we would iterate and sort of refine our algorithms. And then we did all of these shadow phone calls, test phone calls. And we took that very complex algorithm we had and just made it something simple like this. We said, welcome to the, patients will call now and say, welcome to the WestMed Spine Center. Are you looking for a specific provider? And which location are you looking for? Because I've learned now that geography is so much more critical than anything else. Patients just want to come in to see a provider close to their home when they have an acute problem. And then we asked them, how quickly would you like to be seen? And we found through just multiple iterations that geography and then how quickly you want to be seen just solved the problem for us. We don't need to go through these complex algorithms and rules and whatnot. And you can see over here, here's just some prelim data. So we started the WestMed Spine Center about the summer or fall of 2016. And it was a little bit rocky. I mean, we had patients initially who were in Yonkers and being told to go 20 miles away. It was a little bit rocky in the beginning. And you can see over time, I think that in a very iterative fashion, that we've been able to gradually increase the number of phone calls. We get about 43 calls a week coming in, patients calling to come to our WestMed Spine Center with big spikes. This is, I think, around a snowstorm, or I'm not sure exactly what that was, but we don't do any kind of marketing. We have our number on our website. Our primary care doctors know it. We've talked to the local urgent care centers, and we just make it as easy as possible for the patients to get in, trying to meet their request to where they want to go. And you can see that overall that number has just been increasing. But even more so, I told you the goal was to go from 3 weeks down to 24 hours or 48 hours. That's hard. But this is our wait time. So I apologize. We just started collecting data on this about November 2017. So it was 2 weeks back then, but it was really 3 weeks when we first started. And you can see how we're turning down, where now if a patient calls, they're going to come in about 5.6 days. And we think that just by chipping away, by doing this sort of iterative process, auditing our phone calls, refining our message, that we could probably get to that point where we can go to 24 to 48 hours over there. So that's sort of an underground perspective of how we wanted to just take a simple problem like going from a 3-week wait down to, right now, a 5.6 wait. And I just wanted to give you just a little bit of a preview of some of the things that we're working on. That's our first goal, and I'm pretty confident that within 3 months we'll probably get to the 24-hour mark. But what we're trying to do is really just control the whole episode, right? I think that the access is certainly the main issue. But what we're trying to do is take this whole process that we re-engineered and get it down to the point where it's going to be predictable as an episode of what a patient with a spine problem is going to go through. So we can do like a sort of proven care warranty type service on both the non-operative as well as the operative side. I think now that we're getting our process under control of what happens when the patient enters the WestMed system, we're going to be able to get closer and closer to that point. What I'm really excited about is, and some of you have heard about this, is that we're going to start a study with Apple next month where we're going to give our spine surgical patients the Apple Watch, and we're going to try to use the Apple Watch as a method to control the episode from surgery on. If that works, and we're going to learn a lot along the way, what we're hoping to do is start pushing it to earlier and earlier so that ideally, you can imagine a situation where someone who has back pain gets an Apple Watch, and you can control the whole episode from there. And you can eliminate all that kind of variation, which is eventually what everyone's goal should be. There's a lot of steps we have to do before we get to that point. Okay? So with that, I want to just end with these final thoughts. So from the way I see it is, look, I'm a factory worker. I work at the bottom level. So the way I see problems are the problems down here of access, right? But it's pretty clear to me that as we're thinking about this through, if you can control access, then next we're going to try to coordinate our care, which we're almost there. And then we can start thinking about some of these new payment reforms like bundle payments and perhaps even some kind of spine shared savings program. I think to me, the way I see it is that if we're going to crack this $80 billion nut, we sort of have to walk the path this way. And I think I'm pretty confident that if we can follow these steps, that we'll be able to get to that point. So with that, I wanted to thank you. And I want to ask Suellen now to come up here, and she's going to speak to you about her efforts at the West Central Behavioral Health Center. Okay.
Let's hope the slides are here. I was being facetious. I really thought they were going to be there. So they didn't tell you that we saved the best for last, right? So I'll get started. So I'm Suellen Griffin, and as Alok said, that I am the CEO at West Central Behavioral Health, which is one of the 10 community mental health centers in the state of New Hampshire. I migrated from the New York City area. Thank you. I migrated from the New York City area about 10 years ago. Spent my profession in behavioral health, 30 years at the St. Vincent's Hospital level, where I talked about earlier, and the last 10 years up here at West Central Behavioral Health. So one of the things that most of you probably know, if you ever tried to get services for either mental health issues or substance use issues, you're likely to be waiting. There are very few available services when you need them. And so over the years, West Central Behavioral Health has decided that our mission is to reduce the burden of mental health and to improve the quality of life in our community. And part of our vision was that people would receive behavioral health services, mental health and/or substance use services when they needed them. And there was nobody really in the state of New Hampshire of the 10 community mental health centers that was accomplishing that. We all had waiting lists, some more than others. As we stated earlier, my agency was at about 225 people on a waiting list, and I wish they only had to wait 2 to 3 weeks. Some people waited 2 to 3 months. And one of the issues was our workforce shortage. There's very few people that are going into behavioral health services these days. And that's because the changing culture that we have. Actually, it's good news in one sense, but it's bad news in the other. There was a time when women had a choice of teachers, nurses, social workers. Now they can be astronauts. And so the field is not drawing people into the field for any number of reasons, but not the least of which there's a much broader opportunity. And so our workforce shortage is a very real thing. So we got to fall back on that and keep saying, well, we can't get you in because we have a workforce shortage. And that's true. And we did this access redesign and improved the access to our services without hiring one new person. So it was a major feat for the organization, I can tell you that. So let me tell you who we are. So we're a state-designated community mental health center, which means that we have a contract with the state of New Hampshire to provide primarily Medicaid services. We are the safety net in the community. So there's other private providers that will provide services to people that have other insurance, but we primarily take care of people that have a chronic mental illness. These are folks that are going to be with us most of their lives in some level of care. And that was the real issue, is that we didn't figure out how to deal with people that had a chronic mental illness and they should stay with you, but at what level of care should they stay with us? And that was our real problem. We had no throughput. The rumor on the street around here in the Upper Valley and Claremont and Newport, where we have offices, was if you could get into West Central Behavioral Health, you receive very good care. The problem was you couldn't get into West Central Behavioral Health. And so we are freestanding. We have our own board of directors. We're a freestanding nonprofit. We provide mental health and substance use services to people of all ages. We have some children as young as 3, and we do a lot of home care for elderly folks that are as old as 95, I think was the last client that I saw, the oldest client that I saw in our services. Our services include individual and family therapy, medication management, case management, group and supportive employment. One of the big things that we try to understand with our folks is we want to get them to the highest level of functioning that they can get to. Supportive employment is a really big deal for our agency. Our folks that are mentally ill or have a substance use disorder, they want the same things that we want. They want a stable house, they want a job, they want interactive relationships with their family and with their friends. And so a big piece of it is not just treating the illness, it's also trying to improve the quality of their life overall. We have multidisciplinary teams. So we have MDs and advanced practice nurses and master level therapists, and we have case managers and some nurses. And we do a lot of multidisciplinary work because it takes all of those disciplines to really take care of these clients. They have multiple needs when they come to us, and so we really need this kind of multidisciplinary care. We do more than 50% of our work in the community. We work in the local jails that are around here to reduce the recidivism. We work in all of the schools in our area, and we do all the case management as community case management. And so we do more than 50% of our actual services in the community itself, not office-based. So transformational change. It's a real systems approach. This impacted every part of our organization, and every person in our organization had to play a role in making the change to improve access. And we heard this earlier in this 2 days. It's attending equally to the hearts and minds. It's not just figuring out on paper, how do we make this improvement? And you deal with human behavior and the social systems and structures in which they exist. It therefore tends to be multidisciplinary, which we're great at, integrating a range of approaches and methodologies. When I get to the pieces that we had to put in place, this makes more sense. But you can't do it without dealing with the emotional pieces of the staff and of the patients. They play a very important role in getting this done. Why access redesign? Well, it makes sense. People need to be able to access services when they need the services. And so you first ask, what do I expect when I seek medical care? Well, I expect to not wait very long, and that's a very long is your own personal definition. But it certainly isn't 2 to 3 months, I guarantee that. When you picked up the phone and called West Central Behavioral Health, you didn't want nor did you expect to wait that long to get services. Client satisfaction and engagement. Clients who are offered same-day appointments show up to that appointment 91% of the time. Interesting, not 100%, only 91% of the time. They show up if they get an appointment that day. 1 day later, they show up 75% of the time. So you can imagine exponentially, if they're waiting 2 or 3 months, they're not showing up. So when we're calling them 2 or 3 months from now saying, oh, by the way, did you want to come into West Central for services? The answer is no. And so those who move to same-day access see about a 10% increase in kept rate of appointments on average. We're seeing actually a lot more than that, but that's a... And the biggest thing that we had to do was reduce system waste. But before we could reduce the system waste, we had to, sorry, I got distracted by my timekeeper back there. Before we could reduce the system waste, we had to understand what it was. We couldn't reduce it if we couldn't identify it. So everybody thought this was going to happen. So the whole agency thought the minute we open our doors, all hell's going to break loose and everybody in the community is going to be running in to get mental health services. And of course, because you open your doors, one, doesn't mean that everybody has a mental health illness that they're going to come seeking services, and two, even if they do, it doesn't mean they're all going to come at the same time. But that was the fear that our organization had about doing this access redesign. What do? We empowered our leaders. We had to make sure that at the ground level that people could actually make decisions about these changes that we had to make. It couldn't sit with a handful of people in administration. And so it doesn't mean letting people do whatever they want. It means allowing them to make the decisions that they're qualified to make. And so it wasn't top-down driven. It was getting a cohort of people together at different buckets in the organization and letting them make the decision. It also then frees up the executive team to keep monitoring the progress and making changes as we needed to. Required elements. So we had to put all of these things in place in order to be able to make this happen. We started this process in June of 2016. We actually opened the doors to same-day access in June of 2017. It took a year to put all of this in place. And so when I say all of this, we had to do document mapping. We actually were asking date of birth I think 27 times in the course of people's admission to the agency. We didn't know that. So we had to map all of our documents, including our electronic health record and all the questions that we were asking in that electronic health record. It took us about approximately 9 hours to do a typical admission in the agency over a number of days. We had to reduce that to an hour and a half. And so the challenges certainly were there. But that document mapping was a bear if you've ever done it. And of course, we have not done it in the agency in the 40 years in its existence. And every time somebody came in, they'd, well, you need this form, or you need that form, or this is a really good idea. You never went back to look at them to see where there were overlaps. And so we did that work, and that was very, very hard work. Collaborative documentation, don't say that in psychiatry. They think you mean you're going to be typing when you're talking to the person. That's not what that is. Our staff immediately was like, oh, no, the work we do, you have to look at the person. Collaborative documentation is about you have your session, you do 45, 50 minutes, and the end of the session, you bring the patient right around next to you, and you chart together about the things that happened in your session and what you anticipate for the next session. It's collaborative documentation, not concurrent. There's a difference. Centralized scheduling, one of the therapists also think that centralized scheduling is something that's unique to them and that they think it's part of the therapeutic relationship. So take that away from a therapist, that's a tough go. Culturally, they like to talk to the patient, find out what's going on. In studies that have been done about mental health providers that do their own scheduling, it's 300 clinical hours a year per therapist if they do their own scheduling. So you can imagine the efficiency of pulling that away from, not the hardship of doing it, but just the efficiency of centralized scheduling. Most of us, we call our docs, primary care, anybody else, and the front office schedules you. Or if you cancel, you get rescheduled by the front office. You don't speak to your provider. In behavioral health, you often leave a message, they try to call you back, it's a tag game, and lots of time is wasted. So we had to do centralized scheduling, which we did. A functional assessment is a score. It's a numeric score on a verified tool. And with that score, you get a certain level of care. It goes with the amount and type of services that you will get. And then if you need to exceed those services, you certainly can, but you have to fill out a document and give it to our clinical team to validate whether or not more services will be provided. That's the throughput. We didn't have any. You came in the organization, you stayed here until you either died or moved, essentially. And so we developed a level of care system that said you can stay with us, but you don't need exactly the same level of care that you needed when you came in. And so we had to develop some levels of care to move people through the system. And then if they decompensated, you could move them back up to a different level of care. And our no-show policy, about 33% of our clients don't show up for their appointments, and almost half people don't show up for appointments on the first visit. What we did was our intake is now between 8:30 and 11:30 in the morning. There are no specific times. You're told to come in between 8:30 and 11:30 in the morning. And if people don't show up, the slots are still taken up by people that come in. We reduced the no-show rate by almost 20% on that first admission. Because you have one, and we have backups, by the way, so that we don't have people waiting for more than 30 minutes. So if the clinician that's assigned to that particular intake is tied up and somebody else is there, or they came in and it's going to be longer than a 30-minute wait, we have backup therapists that can see somebody. So that no-show policy is significant. We also have a no-show policy that the client signs when they come in, that they agree to a certain number. If you don't show up in a certain number of consecutive visits, then we're going to discharge you, but you have access to our 24-hour, 7-day-a-week emergency services if you need it. And the good thing is that if they do need the services, if they decompensate again, they can turn around and come back in without waiting. Having said that, we started in June, as I said, of 2017. And we had 225 people on our waiting list. And when we rolled this out, what we did is we didn't start with the people on the waiting list. We started with the people that were calling us today. And that was a whole other thing, equity for our staff. Like, they've been out there waiting for 3 months, and you're going to take in the person that called today, because the person that called today is most likely to come in today. And so we started taking people in. As of June of 2017, we didn't put anybody else on a waiting list. We saw them all as they came in, and then we worked down the waiting list. And as you can imagine, only a third of those people came in. Only about a half of the people come in that call us when we tell them to come in now. So now you're going to get seen within 3 to 5 days of calling us. We're going to tell you to come in. And just so you know, the waiting list didn't move from outside to inside. So once you get evaluated, you actually get assigned to see somebody. You don't wait on the inside to see somebody. So it's a true throughput. And so our community has been extremely happy, as our therapists have. We live in this community. It's really hard to walk around the community and people keep saying, we need your services and we can't get in. And so ultimately, the staff bought into this because it was mission-driven, and it was something they believed in as well. I think my time is up. Thank you.
Okay, I'm Andrew Sorenson. I graduated in 2016, yes. And like Alok said, I work for Intermountain Healthcare. We're a health system in the state of Utah, about $7 billion a year, but more importantly, about $420 million in charity care a year. That's a number that's really important to me and I think a key part of our mission. Today I'm going to tell you a little bit about pretty significant change that our organization is undergoing right now. And yeah, trying to distill it down to some things that I think are generalizable and takeaways for everyone that I actually think in hindsight align pretty well with some of the key themes that I've seen and heard during the symposium. So my role at Intermountain, as it says there, is to oversee two pretty large analytics teams, pretty specialized teams. There's 25 people in this group that do pretty hardcore financial analytics and all of the analytics to support our value-based care efforts. It's a lot of fun. I just try not to get in their way. They're a lot smarter than I am. So I think this is one of the things that I've heard is not unique to us. In fact, I think that that's something that's always been cool to me about MHCDS. We work all across the nation, and we have a very shared experience despite some of the idiosyncrasies of the places where we work. And I think what I've heard over the course of the last 2 days is that we're all grappling with this new normal. So just a quick quiz. It's not just us. Which of these organizations over the last year or so had a significant financial downturn? Does anybody know? Ding, ding, ding. So a pretty unique time, I think, in the history of our industry and in all parts of our industry. And meanwhile, along with these downward pressures on revenue and lots of different things going on, I think that we're all starting to think about disruption. And, you know, disruption, I think, will come very, very quickly. It will be companies that can execute moderately well but are very well funded. And I think that this is a great example. You look at Hilton, and like it says, it took 100 years to get to 800,000 beds. It took Airbnb 6. So, you know, think by raise of hands how many of you bought gifts for your kids at Toys R Us this year at Christmas? All right, not very many. So this is going to happen in our industry. I think that the signs are showing that it is happening already in our industry, and I think that part of that will come from the consolidation and mergers that we're all seeing that are happening in very novel ways. And you know, over 5 days in December, looking at just the activity of all of the buys that happened, or 7 days in January, and it's really just staggering, right? And this is our reality. So I want to talk about how Intermountain is responding to this. One of the things that Rashika said last night that really stuck with me, I don't know if any of you also caught this, but did anyone notice how he said that he thinks that consumerism will trump value-based care? I'd never thought of the interaction of those two things as being an either or. I think one will probably force the hand of the other. But we think that really better understanding what our patients want. It sounds weird to say this as if it's a novel idea. I don't think that it's not totally novel, but we should have gotten here sooner. Understanding what our patients want and providing that and totally reshaping our organization to provide those things, we think is the way to get out in front of innovation or disruption. So I'll talk a little bit about what we've done and how we've done it. Just shout, what's the first thing that comes to mind when you look at the silhouette of that shape there on the right? Jukebox. Okay, so in October of last year, Intermountain had its senior leadership retreat, and there we all are. And they sort of make the case for why we need to undergo very significant change and why we need to disrupt ourselves, so to speak. And this became a very common image that was rolled out and something that we see all the time. And the phrasing was, we need to get to a one Intermountain culture and one Intermountain, which is phrasing that I think will very much resonate with this group just based on our backgrounds and what we learned in the program. And one thing that was really interesting to me actually was, I work in the central office, where I think that there was a little different perception of this. So you've actually hit a lot of the things that people started to call this. So I heard the jukebox, that was the one that I saw at first. But then as I would interact with people who worked out in a hospital or in a clinic, it was things like the tombstone or the horseshoe. And so what's really wrapped up in this is to solve with the patient at the top and in the middle, okay? And then reorienting our operations around primary care, community-based care, getting upstream in terms of value, and then our legacy hospital operations. Don't tell anyone that I called them that. Okay, and then being very deliberate about thinking how the things that used to only exist in one of these pillars or the other needs to actually span that. So some anecdotes that I heard and things that have changed already are in these from and to statements. I remember hearing a story along the way about a physician who reported to 4 different medical directors, one in our hospital region, one in their hospital, one in the clinical program, and one in the medical group. And I can see how having 4 bosses that all have a little bit different focus, but also have a very clear opinion on how I should be doing my work, not just what I should be doing, would be really, really difficult. One thing that I actually saw and experienced was, well, our chief operating officer said that as they were going and doing an inventory, they found 1,001 committees. 1,001 committees. And he always jokes that he's sure that there's other committees out there that they didn't find. I'm sure that there are as well. So as we went through this aligning process, one of the things that was really important to make us more nimble and get speed to decision making was to try and get rid of those. And going through this process, we actually decreased, as far as what we've inventoried so far, about 40,000 hours of work a year that is no longer going to happen because committees went away. So one of the other changes that I think will resonate with this group was having physicians report to physicians and having nurses report to nurses to ensure that their voices were being heard through this. So this is what's happened. As of today, about 95% of Intermountain employees, there's about 40,000 employees who work for Intermountain Healthcare. 95% of those employees work in parts of the organization that have been reorganized. I am not one of those employees. In fact, because of the job that I do, I have a solid line into finance and I have a solid line into community health, and I work on an analytics team. And finance and analytics have not been reorganized yet, but it's actually been really enjoyable to be fortunate enough to get to design a lot of how these groups work. That's been a lot of fun, and I actually love thinking about problems like that. And so if I were to say, based on what I've seen happen within our organization and based on the experiences I've had so far, I want to talk about some of the things that I think are generalizable that anyone could do within the companies that they work for. And just kind of a spoiler alert, nothing that you're going to see here is going to seem super sexy and novel. I actually think that this is about doing really mundane things in a very good way, as opposed to these incredibly novel things in sort of a decent way. Some of you may have read this book or heard the TED Talk about Start With Why. If you say this or read the title, you'll get the gist of it and save yourself some time. But I actually, philosophically, I really believe this, and I've seen how this works, that always leading with why it's important for us to be restructuring or reorganizing helps people get over that initial resistance that we've spoken and heard a lot about over the course of this. Okay? So always starting with why and reiterating it is one thing that I would really highly recommend. And one of the things that I actually felt was disruptive and that I heard people say was frustrating for them was it kind of felt like there were some false starts and false finishes, that we would get invited to these big all-hands meetings with the expectation that everything was going to be laid out and only to hear that here's an update. And so one of the pieces of advice that I would really give is to be really clear about the work to be done, be very clear about the timelines, and reiterate that for people as you provide status updates. Because people will really feel unsafe as you go through this process. So I want everyone to shut your eyes for a moment. I'm serious, just shut your eyes for 1 second. Now open them. Now how, when you saw the picture, be honest, how many of you sort of felt your stress level rise a little bit? I loved Paul Argenti. He was one of my favorite professors. I loved all of them, but his classes were always especially entertaining. I was scared to death of him and never wanted to be called on. But I also feel like this became a mantra that we repeated a lot as a class, and I think it's super applicable. Did your years also have this? Was this something that has persisted? Great. I think that these are words to live by. Super basic and straightforward, but as you communicate the why, as you talk about the timelines, tell them you're going to tell them again, all right? I think that can stick with all of us. Molly, how am I doing on time?
We have about 10 minutes left in the session, or 15 minutes left in the session, so go a little bit longer, and we'll still have a little
Okay, I think I can finish in like 25. Is that? All right, no, I'm kidding, I'm pretty close. So 3 things then that I would avoid. We'll spend less time on this, but I also think that these are important. So like I said, I got to participate in a number of different groups that went through a pretty standard process, which was to prepare leaders to meet with a group called Aligning for Clarity. And you would go to Aligning for Clarity to lay out sort of your master plan about how you were going to reorganize as a group. And it was interesting, in each of these teams that I worked on, I was the only common member of these. What I saw over and over and over again was that everyone wanted to jump to organizational structures first. You know, our brains just really like seeing something tangible, and so it actually took a lot of very deliberate effort to keep from doing this over and over and over again. And great leaders that would constantly remind us, look, let's think about function first and reward systems and things like that. And then the other thing, beware of weaponized mantras, I guess you could say. As we rolled out a one Intermountain structure, there was some ambiguity there for people that hadn't had exposure to concepts like that. And what you started to see was people who were trying to accomplish something that they hoped would be uniform across the company, and they would sort of bill it as, the one Intermountain way to do A, B, or C. And so I think really being deliberate and careful about how you communicate what those mantras mean or these guiding principles is really important. And then finally, don't allow things to be solved in a silo. I mentioned this Aligning for Clarity group, and they played an important role in ensuring that everyone didn't solve things with the world, with themselves in the center, I guess, of the universe. As an example, I probably heard 5 or 6 different teams saying that they were going to own strategy or own strategic planning, and wanted to sort of move those teams into their team. So being aware laterally and vertically about what else is going on is incredibly important. So that's been some of our experience. We're still in the midst of it, but we're excited. I guess one other thing that I've heard that I want to touch on is, I didn't mention this in starting with why, but one thing that's actually been incredibly hard for people who work at Intermountain, including myself at points, is that we don't have a burning platform, right? We have this conceptual, I don't know, monster of disruption coming, but it's made it a lot harder to communicate to people what the why is. Anyway, so I'll end with that, and I guess we can go to questions, is that right?
Okay.
Thank you.
Thank you. Okay. So there are microphones on either side, one over there and then one over there. And if anybody has any kind of questions, please. Dina?
So real concrete, so if we had this mantra of one Intermountain, that we wanted to deliver care in a very high quality way. So one Intermountain was intended to mean let's find the best way of doing things and then customize and localize where we needed them to. What started to happen was that people would use the concept of one Intermountain to advance something that they wanted to see happen, even though it wasn't always what was intended by one Intermountain. So solving for structure first, what I saw people do was to get into brainstorming meetings and immediately go up to a whiteboard and start drawing circles and lines in between them with roles and things like that, rather than saying, as a community health group, we need to be able to address the social determinants of health and do value-based contracting, starting with the functions first.
So if I can just piggyback on that. So is the goal to say that you want a total joint replacement to be done the same way across the whole system?
I think that's a good question. So I don't work very heavily in a clinical space, but what I feel like I've seen is if we're going to have patient selection criteria, meaning that a patient needs to get to a certain BMI, they shouldn't be a smoker, and things like that, that those criteria should be similar across the system. But I've also heard a lot of room for finding the right things to customize in rural spaces versus the very urban places that we deliver care.
Good. Yeah.
Just because I got called out.
So Alok, since you prompted me, I'm just a little curious because the way you've got it set up now is that the doctor or an MD is the source of the decision-making, and you're kind of working as a triage, whereas what we hear so much more about is getting PAs or NPs or nurses or other non-physician providers to kind of pick up those decision-making steps before, sending a patient directly to the doctor.
Right.
So why did you choose to do it that way? And is there another scenario where you think the opposite would be more appropriate, or do you think this is the way it should be done?
Right. No, so this is just a first step. So our goal was really just to get just a process engineer. So what was happening was that patients with back pain were, for example, going to see an orthopedic surgeon who didn't want to see back pain, or an orthopedic surgeon who would order an MRI too quickly and stuff. So to some degree, it was about just establishing a process for how these patients were coming in, and it'd be linear. And then now that I think that we're starting to get our process under control, what we're doing now is we're going to start thinking about how to get them to see a PA or NP first. I get data feeds on my colleagues who order x-rays within 30 days, which is not recommended, and or who's ordering an MRI too quickly. And so what we'll probably start to do soon is tell them that probably not appropriate, but then as our process is more under control, we can find the more efficient, let's say, high-value providers who should be seeing these patients first. So it could be a PA or NP, it could be just a high-value doctor who we feel is sort of naturally following what we think are the guidelines, and they'll call the number, and then we can sort of control where that patient's going to be seen first. So we have this very large system, left to its own devices, it would be ping pong. But now we're going to start focusing down, now that we're getting our data feeds, to sort of ensure that they're getting to, if it's a PA or NP, if it's a high-value provider, whoever it should be. I think we're getting close to being tired, but maybe I asked Carol, if you don't mind, to sort of summarize and give us some closing remarks about this level of transformation and the tools that we discussed today. You want to go up there? You want to? Okay. It's close to the end.
So I thought I was incredibly lucky to be on this team. So, I mean, just incredible folks. And, and I can't thank them enough and Molly enough for including me in this group. So I think we were planning this for about 6 months. And so I would love for all of you to have this kind of experience, because you get to hear some of the leaders in healthcare and amazing people as they do their work. And what really struck me, and I'll call Alok out on this, at the very end of the session, the idea was at all the different levels of transformation, right, that it appeared there wasn't just one tool, that we needed different levers to accomplish the work, and that you'll have to pull on all the skill sets and all the tools that you have. And Alok then went on to say, and when we think about change and changing the world and those people that we look to that have made incredible impact in our world throughout history, he said, he goes, someone like a Martin Luther King that you look to for being the example of change is very rare. And this is incredibly hard work. It's challenging. And I kind of smiled because I knew a little bit about the three of them from spending 6 months together with them. And I also knew a little bit about Intermountain Health, because one of my dear friends happens to be the president of the foundation at Intermountain Health. And so I've heard a lot about Intermountain Health. And what I know about Intermountain Health and what I learned about all these wonderful folks here is that you could tell they care about people, right? So they start there with caring about their people. And if you can't care for each other, how can we care for the patients? So I kind of smiled and trying to understand how I was going to go out in the world and do these things. And I remember when we left last year at Investiture, there was certain things that stuck in my head. Professor Wadsworth's statement, do what is hard. And, the lessons I learned from operations, from Professor Chomsky, Argenti, Pino, all of these things, I just had one word in my head that made it possible for me to go forward. And so I thought, after Alok said these words, what was it that really made Martin Luther King so amazing? Why was he so great? Because in fact, if you take him down off the pedestal, he's really, truly only an ordinary man, right? Isn't he really just an ordinary man? But what made him great was his ability to unite humanity, right? And his service that ignited our ability to action for civil rights. That's what made him so great. And so really, he's an ordinary man who did extraordinary things. So I thought about that for myself, and I said, at this point in time, right, when you understand all the things that we know about healthcare, for the second time in our history, the life expectancy in the U.S. has gone down. Living in the U.S. is a health risk. And there's people who've looked at that and said, well, maybe it's about the opiate crisis, maybe it's about social determinants of health. But I could also tell you in New Jersey, we have ALICE. It's Asset Limited Income Constrained Employed. And what that means is it's no longer just about social determinants of health. It's gone beyond poverty. The gap is ever widening. These are people that are employed in New Jersey. We have incredible wealth and incredible poverty, and people in New Jersey just being pushed out because they can't even afford some of the basics. So it's about ALICE as well. And so if you believe in all those things, does this just say to us it's all about despair? Well, if you believe in the possibilities, and when I left here the last time, I believed in what I had learned. I believed in all these professors. So when you believe in the possibilities, you have hope. And neuroscience tells you that if you believe in the possibilities, it actually restructures the brain. And it allows you to see the emerging weak signals. It allows you to see the possibilities. And if you have courage to get up from the chair, you'll move to box 3. So it takes the belief in the possibilities and the courage to act. And then ordinary people can do extraordinary things. And so I say, forget about your old assumptions and your biases. We all have them, right? We all believe in something. We learned, just doing those little games today, that you have to go beyond your biases, go beyond your assumptions, and walk boldly to box 3. So here's a picture. I love this picture, and I wish I could show you the video that went along with this picture, because I left here, and what I learned from just my friend at Intermountain Health, Dave Flood, what I learned was that culture really matters. First it's concentric circles. First, do your own hard work, right? Put your own oxygen mask on, and care about each other, right? And if you can do that, then you can care about the patient. And if you do really hard work and you're willing to bend down, pull others up, and push them forward, make them matter, then amazing things will happen. So what happened here, this is a nurse. So it took me a year. These nurses, when I arrived, had been beaten down by other physicians who were working with them. And, it was the typical ICU rounds where they'd start with, here's the diagnosis, and they would filter all the information towards me, and I was Queen Carol. And I watched these nurses cowering to even make a suggestion about a problem that they saw or an issue with a patient. And I was like, how did we get literally cowering? It broke my heart. And so little by little, I had to help them understand it was okay. You could ask me questions. We're going to do the right thing for this patient. And we redesigned what we were doing, because in this document that she's holding, it's a story about Alice, For All the Love of Alice. And the idea of it was all the things that I'd learned from Dartmouth, I put it into this story, and I was handing it out to the nurses. It was all about box 3 and all the things that you could do. And so little by little, these nurses went from cowering to being empowered and really feeling like they could do something special. And what happened, one of the other nurses went and explained this whole concept, what we were doing, just a transformation concept around trying to deliver on social determinants of health, making people feel like they could take on challenges. Because what will break the human spirit is not the size of the challenge. What will break the human spirit is feeling as if you don't see me, I don't count, and I don't have a say, and I can't contribute. And so I turned it around. I said, let them be the special ones in the group. And what happened is they would give me all this information, and we finally learned, and I know you would know this is all true, they'd give me all this information. I'd come up with a plan based on what they were telling me. And then pastoral care and social services started to stand there saying, that's a very nice plan, but it's not what the patient wants. It doesn't meet the patient's goals. And we stood there realizing we had this all backwards. We turned them into a diagnosis instead of realizing, right, they're a person in the bed. And so if we're going to talk about flipping the ratio, right, from healthcare to social services, well, let's lead with that. So that's what we started to do. And that's what that Lotus Initiative is all about. It's about taking all the lessons learned and transforming our space. So here's the gang in New Jersey. And so, down the bottom there, it says about the arc. So the arc of the moral universe is long, but it bends towards justice. It won't bend alone. It will take relentless, hard work in the trenches every single day, meeting challenges. And if people lead, leaders will eventually follow. So there were some of my colleagues who sat here in the room the other day going, oh my gosh, Austin Pittman, what an amazing CEO. It's a shame we don't have one like that in our organization. We'll never be able to do this. And I just want to say to all of us here at MHCDS, little by little, if each of us, if we're willing to take the lessons learned and go out in your own space, get up from that chair, then collectively we will change the world. So I know we've all had a long day, but thank you. You're a tremendous group, and I feel privileged to be part of this.